Hello and welcome to Isokinetics 101, Episode 2. My name is Rob Potash and I'm with CSMI. This episode, John and Daniel will be inside the clinic for some practical applications for testing and exercise of the shoulder, elbow, wrist, hip, knee, and ankle. This is a live broadcast, so as it's going on, if you have any questions, on the right side of your screen, you can enter your questions, and at the end of the broadcast, John and Daniel will do a little Q&A. Daniel, your turn.
All right, hello everybody. I'm Daniel Bodkin, joined here with John Hisimoto, and it looks like he's going to play a song for us after he grabs one of his guitars off the wall.
You never know, man. You never know.
So today, before we get started, I want to introduce myself. So I graduated from the University of South Florida's Athletic Training and Doctor of Physical Therapy program. And as an athletic training student, I did a rotation with John and saw what he was doing with Isokinetics. And I saw there was a disconnect between what he was doing and what we were learning in the books and lectures and what with other therapists and clinicians thought they were using it for. So I got really involved with John, worked with him as a tech all through PT school, and then as a physical therapist for my first 4 years after I graduated, and got linked up with Rob at CSMI. And so I really wanted to develop the education platform so all the therapists who have access to Isokinetics and future therapists can really kind of take back Isokinetics and they can see what it really is capable of nowadays. So that's who I am, and we're going to get started.
Hi. So, as Daniel was telling you, he's a fantastic young therapist. And I think one of the things you're going to find is that some of the information he's going to be presenting to you is going to be more cutting edge. It's not what we were doing years ago. It's what we're doing now and what we should be doing in the future. So I think it's going to be pretty exciting for you guys to see everything from that standpoint. So Daniel, whenever you're ready, take it over.
So what we're going to talk about today, you're going to see patient-specific techniques, and we're going to show you all the way from passive range of motion through return to play testing. And what we have coming up in the future is we're going to go in depth with each of the techniques you see today, and we're going to get into some case studies at the very end. Now, so I'm a big Star Wars fan, and I think of Master Yoda, and he said it perfectly, that we must unlearn what we have learned about Isokinetics, because as you'll see today, it's capable of a lot more now than it was in the past. Just because someone doesn't understand how it can be used doesn't mean that it doesn't work and that it doesn't have a lot of effectiveness to it. Now, before we get started, I want to give a shout out to Eric Mara and JW Matheson at PT Inquest. Not only are they promoting our program, but I listen to their podcast regularly. They keep me up to date on current research, and they review one article per week in a 45-minute podcast. Now, when we talk about the continuum of care, we talk about starting range of motion with passive motion, working through stability, strength, and control, all the way to return to sports. Now, you have to match where your patient is on this continuum. Not every patient needs to start with step one, mobility. And if you have somebody come in post-op, yes, they're going to start with passive range of motion. But if somebody comes in with just rotator cuff tendinopathy, they might be able to start at the strengthening phase or stability phase. So as I present this to you today, you got to think that as your patient comes in, you have to match where they are in the continuum. All right, keep in mind, just because we're focusing on Isokinetics today, we still perform every type of sports medicine and orthopedic interventions in our plan of care. And it's a misconception that when we use Isokinetics that we're ignoring the closed chain multiplanar functional exercise. So I have a quick video to demonstrate other things that we do regularly. And my little girl, Lily, is going to help me out with that. Woohoo! Jump, jump, jump. There you go, Lily. Jump. Yoga. Yay, good job. You ready? And let's up. Squat up, 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 down, up, up, up tall, down. This one, 17. Good job. Good job, Lily. Yeah. Yeah, you got another one? Got it? 18. Good job, Lily. You got another one? 19. Good job. Oh. Can you throw it to me, Lily? All right, just remember, if rehab is a pizza, isokinetics and dynamometer use is a slice of that pizza. It's not the entire pizza. So let's go ahead and get into some of the videos today. All right, in this first view, I have our patient in the prone position for passive knee flexion and extension. This is Chris Fernandez. He's one of our athletic trainers currently working with John. This position is good for hamstrings and quad strains, as well as any other knee pathology when you're trying to work beyond 90 degrees of flexion or you're wanting to mobilize one of those muscles. All right, what I'm doing now, I'm going to palpate his hamstrings. I'm going to do some soft tissue work on him, but I'm going to come back to this at the end. We're going to show some soft tissue techniques. In this video, we see John working with Bradley Moorer, who's in his final clinical rotation as a DPT student. Now, this is the common position for the knee, and this is used for more than just post-op knees, but any knee soreness, stiffness, or swelling, and we want to increase their motion and reduce their symptoms. Now, what John is doing here is he's handing Bradley the safety stop switch. And we're going to give John the Academy Award for his acting. In this video, we'll see my patient who had a truck bed fall on his knee. It shattered his patella into 5 pieces. After surgery and 4 weeks of immobilization, his range of motion was very slow to return. And he was stuck at 55 to 60 degrees of flexion, and he plateaued there for about 2 weeks. Now, currently, where I work, I'm 45 minutes south of the clinic that has the HUMAC norm. So this was the first time we got him on the machine, and we were able to get him to 73 degrees passively. The nice thing about the software is that as his knee loosens up, you can increase his motion by as little as 1 degree at a time. You can even put stretches at the end of the motion on the fly, and you do it all while the exercise is occurring. So it makes increasing the range of motion very easy and comfortable. Now, the science behind CPM is that as the joint is moved through its open and closed pack positions, the pressure increases and decreases in a sinusoidal fashion, and that creates a pumping effect. This reduces hemarthrosis and reduces effusion. This also acts on the periarticular tissues, renormalizing resting tissue tension links of the ligaments, tendons, muscles, and fascia. All right, what I'm having him do now is contract his hamstrings lightly into flexion as the machine is moving into flexion. So that's reducing his extensor tissue tension from about 30 foot-pounds of torque to less than 5. And that allowed him to get to 78 degrees today comfortably. So this is really an example of active assisted range of motion. So he doesn't have the ability to move into that motion on his own, but the machine is helping him. Now, if we look at the screen, The graph on the right shows him contracting with the hamstrings, increasing positive torque until he gets into full flexion, and that's when his extensor tightness is taken over. Now, each rep is a different color, so that allows us to see that as the exercise progresses, his tissue tension is reducing on each rep. It also gives him great feedback to know how he's doing. You can see on that last rep, he did really well. He gave me a good effort on this. Now on this rep, you can see that black line is kind of sagging, so I had to remind him, hey, make sure you contract as it pulls up. So it's a great visual feedback for him. All right, here we see the ankle setup. And we all know that early mobilization after ankle sprains has been shown to improve outcomes and get our athletes back on the field faster. So here you can see plantar and dorsiflexion, but you can also do this in the prone position that has the knee fully extended. When you're working through CPM, you want to keep it slow. Usually 3 to 5 degrees and up to at most 10 degrees per second, so very slow motion. And here we can see inversion and eversion of the ankle. Your larger joints with larger ranges of motion, you can work them about 10 degrees per second, but small joints like the wrist, elbow, and ankle, you're going to run it slower, 3 to 5 degrees per second. Now in this video, the hip is being moved through internal and external rotation, which your arthritis patients are going to absolutely love. And it's also very easy to set up. Now, one great advantage of CPM is that once you set your patients up and give them the stop switch, it frees you up as a clinician to check on other patients, do some documenting, or just simply catch your breath. If you're like John, you're probably going to tell some stories about which cities have the best pizza places. Now, because the treatment is slow and smooth and predictable with the same parameters on every rep, your patient will be much less guarded and more comfortable compared to traditional passive range of motion with the therapist. In this video, Bradley's demonstrating passive shoulder flexion. Now, the first few times I mobilize the shoulder, I do it manually. But after that, I like to go with the dynamometer. And each time I do it on the machine, I'll turn the chair to the side, run their shoulder through a few passes just so I can see how they're moving that day. Now, I found that most of my patients are significantly less guarded on the machine and find it more comfortable. Like with the ankle setup you saw earlier, this setup is a little more complex, but with practice, you can get good at setting it up quickly. I mentioned earlier that you can change the parameters during the exercise. For example, for this one, if we start him at when he says his shoulder is tight, say 100 degrees, as he loosens up, I can increase that range of motion a few degrees at a time, but we want to keep them pain-free. It's okay to put a stretch on it and it's okay for them to feel a stretch, but we don't want to have any pain, and you have to keep your range of motion limitations post-op in mind. And you're going to see this in much more detail in next month's webinar on CPM. Now this is the position for external and internal rotation. If your shoulder patient comes in complaining of general tightness, aching, soreness, this is your go-to position for CPM. It's much faster to set up and it really loosens them up quickly. And again, keep in mind any of your range of motion limitations post-op, and that goes for any position you see today. This video shows passive motion for the elbow, which is great for any of your patients after Tommy John or bicep surgery. Now this patient was actually further along in the rehab when I shot the video, but if he were in the mobility phase, I would have adjusted his grip by rotating the adapter. That would have put his wrist in a neutral position and allowed him to relax his flexor mass and pronator teres. Now, if you want to mobilize this patient after Tommy John, you could also have them sitting up and just mobilize the wrist joint as well. Now this video here, I'm doing some soft tissue techniques. CPM on the machine is a perfect opportunity to perform soft tissue mobilization either manually or with instrument-assisted mobilization. In the video, I'm using a Hawk Grips tool, and I'm working on Chris's lateral hamstring and IT band. I'm using different fanning, brushing, sweeping, strumming, framing, and pin and stretch techniques. Now today, I'm having him completely relax, but you can also perform this in an active format to where the patient's loading the muscle eccentrically through the motion. And the ankle position is great for your patients with post-tib tendinopathy, as well as any patient with lateral ankle sprain. So this is a great ankle treatment for soft tissue work. All right, so we're going to go directly into stability training. Now, the first position I'm showing you here is for prone hamstring contraction. And I chose this video because the exercise protocol the athlete's performing, he's doing one repetition in each position before moving to the next. And we're having them work every 10 degrees of the range of motion. On the biofeedback screen, you can see a torque bar raise up as the athlete pulls into the adapter pad. Now, typically we have our athletes perform 3 to 5 reps in each position before the machine moves to the next. Remember, the key to multi-angle isometrics is that the exercise is performed submaximally. Now, there's a few exceptions to that, but the goal here is for neuromuscular re-education. It's not about strengthening. All right, next, I'm going to show you how to navigate the menus on the HUMAC software. On the main screen, I'm selecting exercise, then selecting the joint and position. Then I'm choosing the protocol from the drop-down. Now, when we cover each exercise phase in the upcoming months, we'll spend more time on navigating menus. On the exercise setup screen, I have selected a protocol for knee extension isometrics from 10 degrees through 70 degrees. Now on this screen, you can choose to start an athlete at any point in the range of motion. So a lot of people like to start the post-op ACLs at 40 degrees and run them through 90 degrees. And that's perfect. You can even create a protocol directly for that. Now we typically will start our post-op ACLs on isometrics at about 2 to 3 weeks post-op. There's a couple ways that we can do this to make this safe. So at 4 to 6 weeks, they can start loading gently. The way we do this is by doing a proximal pad placement. By using either a proximal pad placement or an anti-shear device, you can negate the shearing effect on the tibia. So here's 2 articles that discuss this. as well as a systematic review done in 2010, and it found that both open and closed kinetic exercises are safe for patients with ACL reconstruction. Now, in next month's webinar, we'll go into detailed setups at different joints and positions, but the key for the alignment is aligning them proximal to distal, and you align the axis of rotation to the axis of the joint, and you always check the range of motion. So next, we set the anatomic zero. Now, if your patient is not able to achieve full extension, you can align this at any angle, so long as you designate the angle that they're in. Bradley has full extension, so I kept it at 0. This next screen, you set the total range of motion for the exercise. So once you set flexion and extension angles, you're given mechanical stop settings. Once you set that for safety, you can click OK and begin. Now, everything you saw in the software, you can do this from the dashboard mode, and that puts everything all in one location, and it speeds up the setup. Now I'm cueing Bradley here to engage his quad lightly and press up into the adapter arm. Now Bradley is not currently post-op, so his first angle today is 10 degrees. But again, typically our post-op ACLs will start them at 20 to 30 degrees. Now I want to pause again because a lot of therapists will start their patients at 40 degrees and through 90 degrees, and that's fine. But again, we're using very light torque amounts, and with that proximal pad placement, you're safe to do these angles, again, 4 to 6 weeks post-op. Our patients never have any difficulties or any adverse responses to this. Now, as we zoom into the screen, you can see Bradley's only producing about 5 to 6 foot-pounds of torque. Again, the goal here is neuromuscular re-education of the quad, not strength. Now, I said earlier, we typically have our protocol set for 3 to 5 reps in each angle, but to save time on the video, I'm fast forwarding to different angles. And speaking of different angles, let's say you're working with somebody who has discomfort, say at 50 or 60 degrees, you can skip that angle easily. Now, here's another safety feature. This is called targets. This keeps your patient from overproducing too much torque. If they go above or fall below the target window, the exercise pauses until they get back in the window. I currently have it set to 5 to 10 foot-pounds. There's another safety mechanism you can do. One step further, you can write your exercise protocol to shut off if your patient achieves a certain threshold. And this is good. If you have an impulsive patient who might try to see how hard they can push if you walk away, that's going to keep them from doing that. Now here you see Bradley again setting up Chris for shoulder ER multi-angle isometrics. Well, we have him starting off at 30 degrees of external rotation, and he's working every 10 degrees down to 30 degrees of internal rotation. With your rotator cuff tendinopathies and general shoulder pain, you can begin this immediately, so long as they're pain-free. But with post-op, you need to delay this. With standard rotator cuff repair, Bankart, and total shoulders, you need to wait until at least 6 to 8 weeks post-op. For slap repairs, you can start it earlier, about 2 to 3 weeks in, but remember, you got to keep your range of motion limitations in mind. Now, Chris is doing 5 reps in each set, but I'm fast forwarding again to save time on the video. I didn't show it today, but isometrics are great interventions for the ankles, for the ankle after sprains, foot surgeries, Achilles tendon repairs. Isometrics are also really good for your hip patients, and they're going to love that intervention. Okay, so next we're going to move on to strength training. All right, so here, if we look at the graph on the left, this is plotting force on the y-axis and range of motion on the x. And this is actually an example of isokinetic exercise where the resistance is variable and it changes throughout the range of motion. A muscle or a joint will be weaker at end ranges of the motion and it's stronger in mid-range. And this is due to the lever arm advantages as well as cross-bridge formation of the muscle. The graph on the right plots percentage of muscle capacity throughout the range of motion. Because the machine gives less resistance where we're weaker, but more resistance where we're stronger, we maximize the muscle output throughout the entire range of motion. And it's an optimal way to strengthen versus isotonics, which we'll see shortly. All right, here we have the force velocity curve that John touched on last month. And again, traditional isokinetics, they're working fast speed concentric. But if you look at the order of torque capacity, fast speed concentrics, that's actually the lowest producer of torque capacity, followed next by slow concentrics and then isometrics. So you can produce more torque isometrically than you can concentrically. And then to get even more torque, we start with slow eccentrics. And to get even more torque, we progress those slow eccentrics faster and faster. So here's our strength training videos. Now I'm going to show you a series of eccentric isokinetic progressions that John talked about last week. Here we see our athlete performing eccentric unloading for her quads after ACL reconstruction. Now this intervention is actually performed before you do isometrics. Because with isometrics, you have to produce positive force into the adapter pad, and with eccentric unloading, the muscle only has to overcome the weight of the limb. For ACL patients, we usually start this 2 to 4 weeks after surgery, depending on the patient. And you can see in the video that the machine lifts the patient up concentrically, and at the top of the motion at full extension, I tell her to engage her quad isometrically and then lower or unload the weight of the limb on the way down. And our patient here is unable to achieve full active extension, but she does have it passively. So you can even consider this an active assisted range of motion intervention. Overall, eccentric unloading is an important step in early rehab as it allows for safe neuromuscular reeducation and proprioception. A lot of our patients are already doing this at home, moving through the range of motion actively. What makes it a better intervention is that they have to match the speed of the machine, keeping between the adapter pad and the strap. And we set the machine nice and slow, 5 degrees per second eccentrically. In the concentric lift, we have it set to 10 degrees per second. Now, between unloading and this video is when you do your multi-angle isometrics. So now our patient has progressed to active contractions against eccentric loads. And we start this around week 6 post-op. And we're only going 5 degrees per second. Remember, slow eccentrics for lower load. The force production and torque are still kept minimal, and the focus is on neural control of eccentric contraction. When we do progress the patient, we have them contract 5 degrees per second faster in progressive sets. For example, she's performing 3 sets of 10 here. The first is going to be 10 degrees per second, active eccentric. Set 2 is 15 degrees per second, and set 3 is 20 degrees per second. We always have the concentric resting speed twice that of the active eccentric speed. For ACLs, we like to keep the velocity the same for 1 to 2 weeks or 2 to 3 visits, depending on when they come in. And then we progress to the next exercise protocol. And we do this when they have good torque curves and they're pain-free and they have good control. Now the next protocol increases the set only by 5 degrees per second. So the next protocol would be 15, 20, 25 degrees per second. And then the next would be 20, 25, 30, and finally 25, 30, 35 degrees per second. Now I'm naming these for the active eccentric exercising speed. John likes to name his for the passive concentric speed, which is double that of the exercise. The protocol is the same nonetheless. Now as the speeds progress, you can have the athlete also give us more torque production as well. Once they're in these progressive eccentric sets, they start their first set at 25% effort, working up to 50% effort of the remaining sets. Now here you see eccentric loading for the hamstrings and prone. Up to this point, we've been using slow speeds. And John told you last month that that means that the degrees per second velocity is half that of the range of motion. In the next video, we're going to see medium speeds, and that's what we call deceleration training. Remember back to the force velocity curve. As the speeds increase in eccentric mode, the amount of torque that we can produce increases also. So now the velocity is 1/2 to 1 that of the range of motion. So here the hamstring is contracting from 80 to 10 degrees, so 70 total degrees range of motion, but the velocity is 40 degrees per second in deceleration. Once the athlete is progressed into deceleration training, we have them give up to 75% effort in each set. And we typically begin this for ACLs around 12 weeks post-op. In this video, we see our athlete performing deceleration training for the hamstrings and sitting. We can also do it for the quad though, just like this. Not only is he performing the eccentric contraction, but I'm having him do the concentric contraction as well. We start this around week 16 post-op. Remember, the concentric contraction uses 70% more oxygen. So this works on strengthening, but it also really does a good job of working muscle endurance as well. Here we see eccentric loading for everter strengthening following ankle sprains. Now, because we're having them perform exercise eccentrically, the torque curve on the screen is actually going down below the 0 horizontal line. But that just implies the direction. The direction of force is opposite that of the movement. That's why it's going down, but it's just the direction. So the patient is pressing out as the machine moves them in, and that's going to eccentrically load their everters. Our patient here is performing eccentric bicep contractions. He's pulling up as the elbow is moved into extension. And this is helpful for regaining bicep strength after any bicipital procedures. Now, this patient is actually one of our Tommy John's patients. So I'm exercising his biceps here, but you're also going to see us working his triceps shortly. So it's not only about strength training here. Remember, eccentrics have a completely different neural firing pattern, and you don't get those neural adaptations unless you're training them eccentrically. So it's absolutely essential that you work these muscle groups eccentrically. All right, in this video, the athlete is performing eccentric loading for the pronator teres. Now, this along with the wrist flexor mass strengthening is very helpful after any medial elbow injury or surgery. And if you look closely, you can see his pronator teres firing really well in the exercise. Now, you can start these positions for Tommy John's safely around the 9th week of surgery, post-op. Remember, low load, low torque amounts. All right, here you see Bradley aligning and setting up Chris for eccentric external rotation. And this is the position of exercise for the shoulder in the scapular plane. And it's about 45 degrees of abduction and 20 to 30 degrees of horizontal adduction. I included this whole video because I want you to see how quickly you can set the patient up, start the exercise, and get him going. Now he's checking him from all angles. You got to make sure that your setups are precise. So next, Bradley's going to find the neutral position for ER-IR. And what he's feeling for is the bicipital groove. So once he finds neutral on the machine, he's going to click anatomic 0. All right, now he's going to set the total range of motion for the exercise from 30 degrees of external rotation through 30 degrees of internal rotation. So a total of 60 degrees. Now, after he sets the range of motion, the software gives him his mechanical safety stops. That's very important. If there's any one thing that's important about your setup is always making sure your mechanical safeties are set. Now, the exercise he's performing here is eccentric unloading. And you can start this safely for your rotator cuff repairs when the patient is starting their active range of motion exercises. That's typically 6 to 8 weeks post-op, depending on the patient. Now, I'm going to skip ahead for the shoulder eccentric progressions as it follows the same rules for the knee with the same speeds and the torque values or the percentage of effort for your torque that we already talked about for the knee. So the machine's lifting him up, he's lifting off the pad and lowering down the weight of his own arm. and he's hovering just above that adapter arm. Now I skipped ahead to deceleration training here, and I wanted to include this video because this is showing the athlete working on the KINCOM. So you can't, it's not just for the HUMAC norm. The exact same principles we're talking about today, you can apply to the KINCOM, to the Biodex, and it's applied to any of these machines across the board. So that was strength training. Next, we're going to move on to control training. And we do control training with isotonics. Now, if we look at the graph on the left, it's plotting force on the y-axis and range of motion on the x. And this is an example of an isotonic exercise where the resistance is fixed and it remains unchanged throughout the range of motion. On the graph on the right, it plots the percentage of muscle capacity throughout the same range of motion. I mentioned earlier that a muscle or joint will be weaker at the end ranges of motion and stronger in the middle. Because we're weaker at the different points, we get the sticking points. And that's where we're not strong enough to complete a full repetition. So we have to make the weight lighter, and that accommodates only for our weak points. Because of this, we're not truly maximizing the muscle output throughout the whole range of motion. But I'm going to show you a few techniques that we can use on the dynamometer to make up for that. Now, with control training, there's a lot of new interventions that can be performed on a dynamometer. And I like to call this dynamic isotonics, as it combines isotonics with proprioception and biofeedback. This first one is called pacing bar. So with this, we have the bar set to move 2 seconds concentrically and then 4 seconds eccentrically. And the patient tries to keep his line within the bar as it moves up and down the screen. Now, we typically do this with very light weight and most of the time no weight at all. This is more for teaching them the pace that they're going to be using with the gym program. Okay, here we see the interactive path. Now, not only does this work strength training with position control, but the software allows us to do what I call eccentric overload. So where we can set the eccentric load separate from the concentric. So for example, if the concentric is set to 10 foot-pounds, we set the eccentric 30% heavier or 13 foot-pounds. And that's a good starting point for the knee, but for the shoulder, you have to go lighter. It's about 3 and 4. Now I try to keep it at 30% eccentric heavier because that's what research tells us that the eccentric can be. Now with doing this, this challenges the neurologic control system to a much greater extent than you get with just general isotonic strengthening. Now in the feedback, Chris is controlling the ball position. He's attempting to keep it in the blue path as it moves across the screen. Now a nice feature is that you can control the torque value during the exercise. So if he fatigues and gets tired, you can always reduce the load. Now this 30% eccentric overload gives you a quick stretch similar with manual PNF exercise. This quick eccentric stretch induces the stretch shortening cycle or the plyometric effect. So this actually helps prepare your patients for plyometric training before it's actually safe for them to do plyometrics. Now this next one I want to show you is breakout. This is actually usually one of the most favorite activities for our patients with dynamic isotonics. Now the patient here is performing plantar flexion for Achilles tendinopathy. With all these isotonics, we're only working one muscle group at a time. So even though the ankle is moving back and forth, he's controlling it with his calf the entire time. Now, if any of you are unfamiliar with the video game that you see here, this is from the 80s, the Atari console called Breakout. You're also going to see Pong here in a moment. And this just kind of shows Rob and Rich Payash as they're dating themselves with this. Now, the patient controls the paddle across the bottom of the screen. And the goal is to not let the ball get past you. It reflects up and it breaks bricks. With the ankle and other small joints like the wrist, I don't put that 30% eccentric overload on. The goal is to keep the resistance very light for those joints. And actually, lots of times I won't put any resistance on at all. And early on with any joint, I like to do this without any resistance and just work proprioception and position control. Now you can see this is a tough intervention here. Even without any resistance, it's tough to control that position. All right, here we have interactive line, and it's just like the interactive path we saw earlier. But here they're going to control a pair of dots, and as the line moves across the screen, the patient attempts to keep the line centered between the two dots. Now the software comes preloaded with all these protocols, but you can actually write your own, and it's very easy to do. And if you look at the bottom of the screen, you can see where you can click and change the torque values on the fly. And you can also see that I have the 30% eccentric overload in place with 10 foot-pounds concentrically and 13 foot-pounds eccentrically. Now Bradley's doing this exercise here, and I wanted to tell you about him because he's in his last rotation as a PT student, but he was actually a patient of John's when he had his knee surgeries in the past. And then that led Bradley into physical therapy. So Bradley, when he got into physical therapy school, just like how I did, he started working with John as a tech. So he was getting his, getting all this knowledge from a very early point. And you saw him in a lot of these videos doing the setups, running through the software. So he is very highly educated in isokinetics, and I'm excited to work with him in the future. All right, in this video, we see Bradley playing one of the most classic video games there is, and it's Pong. The patient controls the paddle on the left and the computer controls the paddle on the right. And just like with Breakout, you can make this more or less difficult by adjusting the paddle size, the ball speed and acceleration, and you can vary those eccentric concentric ratios. And you can also change the computer skill. Now I currently have the ball to accelerate with each deflection, so it's going to get faster each time. All right, this is power training, and this is one of the, I think, the most exciting things you can use this machine for that currently wasn't used. So this is working on rate of force production concentrically and then the eccentric control. And again, I like to use that 30% eccentric overload. So rate of force production and power have been very hot topics in the last few years when it comes to returning our patients to sports and getting that strength up. So it's not just about how much torque they can produce, but how quickly they can produce it. And this is one of the great interventions for rate of force production. So next we have response time, and this is the last video, and it's a great proprioception trainer. So the patient controls the purple ball. The ring puts a ring on the screen, and the patient places the ball in the ring as quickly as they can, and they try to keep it in the ring. Each rep is recorded on the left, and it's recorded for response time and stability time. Now I use this and other proprioception trainers early in the rehab process around week 6. I don't use any external load for them. This is also really good for the end of a session when our patient's in a good fatigue state. Okay, lastly for today, we're going to get into testing. Now, isometric testing is the first protocol we're going to look at. For ACLs, we can perform isometric testing at 60 degrees in the range of motion starting at week 8, and then I like to repeat it again at week 12. Now, after week 12, I like to move on to the standard isokinetic test, and I do that around week 16, and then I go into the interrupted stroke test. Now, for your rotator cuff repairs, for isometric testing, the earliest you can do this is week 12, and at that point, it's just a baseline, and then you can repeat it again at week 16 before you move on to the more dynamic testing. Now, for your non-surgical patients, including your older patients, isometric tests are a perfect way to assess their strength and progression, because it's basically a manual muscle test, but it gives you a very precise measurement. Now, in the protocol, we do warm-up sets. We do 2 reps at 25% effort, 2 at 50, 2 at 75, and then 1 at 100%. We have them hold for 5 seconds with a 10-second rest in between. After they warm up, the patient gets a 1-minute rest before the test. The test itself is 3 reps with that same 5-second hold. The 3 reps are averaged together, and they put that in the report. And here's actually an example of a test report of a patient that I'm going to do my case study on later in the year. So in the isometric test report, not only do you get the peak torque and the average torque, but you get the rate of force production. You know, how quickly can they get to that torque? And that's, again, that's a very hot topic in sports medicine right now. So on this graph on the top, that's the graph for the quadriceps, and then the bottom graph and the numbers are for the hamstring. All right, next we have the standard traditional concentric quad and hamstring test. Now for ACLs, I only perform this at week 16 and week 20, and then I move on to the interrupted stroke test because that gives you an eccentric function as well. Now for the standard test, I do both testing at 60 degrees per second and 300 degrees per second. It's a very fast, it's a very easy test to perform, but it doesn't give you that eccentric data. Remember, concentric gives you less torque produced than you can get with eccentric. So it's a safe test to do before you do eccentrics. Here's a test report of a standard isokinetic test, and it's showing significant deficits in both muscle groups here. All right, lastly, this is the interrupted stroke test, and this is our primary test that we use. It gives us a chance to look at both concentric and eccentric functions. And for the knee, I test the quadriceps and hamstrings. For the ankle, I test both inverters, everters. And for the shoulder, I test internal and external rotation. That way, not only do I get concentric and eccentric, but it gives me a chance to look at the joint as a whole. Now, this is a far superior test because it gives you that all-important eccentric data. And because you can select and deselect reps that you want to count, you get a much better coefficient of variance. Now, the downside of this test is that for ACLs, you have to wait until week 20 to perform this. So I test them at week 20, and that's pretty much a baseline, 5 months. Then we retest 4 to 6 weeks later at 6 months to see how close they are for return to sports. The other downside of this, your patient will have significant delayed onset muscle soreness the next day. They're loading eccentrically with full effort, so they're going to get muscle soreness with this. Now, the warm-up with this is I'm having them do 2 warm-up reps for concentric and eccentric. Now, there's 2 reps at 50% effort, at 75% effort, and then 1 rep for 100% effort. First, we warm up and test the quad and then the hamstring of the uninvolved limb, and then we move to the involved limb. This test can take you about 30 minutes to do the full warm up and test reps of both legs. And that's if the patient's never performed eccentric loading on the dynamometer. But if you have somebody that you've been working with and they're used to loading eccentrically, you can knock it out in 15 minutes. Now, just like before, you have 3 reps that you record in each mode of contraction, but you have 10 opportunities or 10 reps to get those 3 reps here. What's cool on this is you can actually zoom in and analyze your reps you want to select. So on here, you can see I selected rep 1 and 3, but rep 2, that's the green line. It's not as good a rep. Not only do I see that from the torque value, but I saw that graphically as well. So you can select and deselect the reps that you want to use on the fly. Now I'm going to fast forward here so we can look at the test report. That's coming up here in just a moment. All right, so here's a sample report for the interrupted stroke test. Now the first page, this is entirely the quad. So the graph on the left is the concentric data and the graph on the right is the eccentric data. Now the second page is for the hamstrings. Again, the concentric graph and data is on the left and the eccentric is on the right. Now we're not just looking at peak torque, and we're not just looking at ratios, but we're looking at peak torque values of concentric and eccentric. We're looking at work values. We're looking at power, rate of force production. So there's a lot of things that we're analyzing with that interrupted stroke test. Okay. So that was all the videos that we have for today. So I want to open up the floor to any questions that we may have. And I also want to invite John and Rob back into the webinar.
Thanks, Daniel. It was a great webinar, and we appreciate everything that you're able to do for us. We do have a couple of questions, though, for you. So we're looking in to what people have been writing back, and one of the questions that we had today was, do you use blood flow restriction with your dynamometer?
So actually, I have it, and I'm really excited to get into that. We do have a group out of Germany that have been doing this for years. This is something that we're going to discuss in our strength training and isokinetic webinar. We'll go into it a little bit more detail. So I don't want to jump the gun on that until we have all of the data put together in one place. But yes, that is being done, but not by, I'm not doing it.
Okay. And when do you test? And I know you kind of talked about that, but the question was, when do you test and how do you bill for it?
So yes, I did talk about with a lot of our post-ops, you know, when you're looking at your rotator cuffs, I'll test them isometrically starting at week 12 as a baseline and then a follow-up at week 16 before we move on to the interrupted stroke test around week 20. With our ACLs, we'll start them out week 8 and 12 isometrically. I like to do the standard isokinetic test at week 16 just to get a little bit more dynamic before we go to the interrupted stroke test. But we actually test a lot of people walking in the door on their first visit. You know, if they're coming in and they just have general shoulder pain or knee pain, you know, John, you've done this many times. We put them on the machine first day and do a test and find out, okay, is this person able to fire eccentrically? And most of the time, their concentric looks great, but that eccentric curve just shuts down completely. And that usually helps guide our plan of care.
Yeah, a lot of people have to recognize that you can have a neurologic shutdown eccentrically that doesn't seem to affect the concentric measurements. So, you know, it's been written up, you know, in the past when they talk about anterior knee pain, and we see it with ACLs, we see it with a lot of things. But one of the last questions that we'll kind of pose back to you, because you gave us so much information tonight to kind of look at, and I want everybody to know that we will be breaking each one of these down individually. So we'll be talking about passive, isometric, isokinetic, and getting into testing on a step-by-step procedures, and then going into isotonic from a more functional standpoint. But one of the questions, and it's one I've gotten for years, is are you using open kinetic chain exercises before closed kinetic?
Okay, so we're using them, or we're using isokinetics as part of the plan of care. So let's say for ACLs, because that's the hot topic. When they show up week 1 post-op, you know, we're working on regaining quad control, getting full knee extension, patellar mobility. Well, that's when we're working on CPM. Now, around week 4 to 6, when they're getting into mini squats, forward lunges, some of their balance and proprioception, that's when they're getting into their multi-angle isometrics and eccentric unloading. As they're progressing with those and they're getting deeper in the range of motion, they're going multiple planes, they're working on step downs, they're getting more dynamic. That's when we're running them through their eccentric progression. As they're getting into agilities and plyometrics around week 12 to 16, that's when we're getting on the eccentric or the deceleration training, the dynamic isotonics, the power training. So everything we're doing with the dynamometer is going right along with it. There's not one before the other because they run together. Right. I hope that can answer that. And you'll see that as we do the next monthly webinars.
And I would tell everybody to go ahead and continue to post your questions to us, because it's a good opportunity for us to kind of look at some of these things and address them in the future webinars that we're going through. So send them to Rob through CSMI, or you can post them directly to Daniel and I, and we'll share them back and forth. But Rob, you got anything else that you want to add? Because I know we're coming up to the end of this session.
No, I want to thank Daniel for doing a good job, and John, you too. Thanks everybody for chiming in. You're welcome to share the link to the website, to the webinar, to get others involved. And yeah, as John said, if you have other topics you want us to touch on, we're more than happy to touch on them. We just need your input. This is episode 2. We have 10 to go. So give us your thoughts, and thanks for watching.
All right. Thank you, everybody.
Thank you, guys. See ya.
Cheers. Have a good night.